Good morning. My name is Swati Rao. I'm one of the second year general cardiology fellows at University of Cincinnati, Ohio. Today I present to you a case of coronary vasospasm resulting in recurrent ACS. Coronary artery spasm used to be a destination diagnosis with medical management as the sole available treatment. With the advent of intracoronary imaging, a closer relationship between early atherosclerosis and spasm has been uncovered today. A proactive approach to the diagnosis with provocative testing and definitive treatment has hence become very important. Despite this, awareness about the importance of establishing a diagnosis and its prognostic implications is lacking. We present to you a case of missed diagnosis of coronary artery spasm resulting in recurrent ACS and the definitive testing that was then undertaken. A 51-year-old man presented to the ED complaining of episodic angina that he described as an elephant sitting on his chest. His EKG showed no ischemic changes and high sensitivity troponin was only 14. He was admitted for observation. His chest pain recurred with his repeat EKG showing anterior ST elevations and a high sensitivity troponin that had risen to 2500. Emergency coronary angiogram was done after a code STEMI was called. It showed only luminal irregularities without evidence of a culprit lesion. He was transferred to CVICU and the episode recurred on day 2, now with evidence of diffuse ST depressions on EKG. His troponins peaked at 8100 before downtrending. On chart review, he had had multiple ER visits since 2017 with similar complaints, receiving multiple angiograms that showed sluggish coronary flow without evidence of overt pathology. He was taken back to the cath lab for an acetylcholine challenge to assess for coronary artery spasm. With 20 micrograms, a mild spasm was seen in mid-LAD and ostial diag1. Patient remained asymptomatic and EKG showed non-specific T-wave inversions. At 50 micrograms, a severe flow-limiting spasm was seen from mid to distal LAD with occurrence of severe angina and non-specific T-wave inversions on EKG. He was given 600 micrograms of intracoronary nitroglycerin, resulting in complete reversal of the vasospasm, resolution of symptoms, and normalization of EKG. With the diagnosis of diffuse spasm, he was discharged on diltiazem and isosorbide mononitrate titrated to achieve symptom relief. These are the angiogram images showing the dramatic vasospasm that gets relieved with nitroglycerin. Coronary artery spasm is a relatively common cause of ischemia with no obstructed coronary arteries, its transient nature frequently resulting in missed diagnosis. Depending on the duration of vasospasm, presentation ranges from silent ischemia to overt STEMI, arrhythmias, and even sudden cardiac death. Anatomically, CAS can be diffuse or focal. Intracoronary imaging has uncovered fundamentally different pathogenesis between these two types, with focal types resulting from early atherosclerosis-induced vasoreactivity and diffuse types resulting from a constitutional disorder of vasomotion. Their treatment strategies, therefore, are very different. CAS is seen to also accelerate atherosclerosis by platelet activation and formation of microthrombi. Gold standard for diagnosis is intracoronary provocation testing with acetylcholine or ergonovine. Response is assessed by angiogram showing coronary vasoconstriction or echocardiogram showing new wall motion abnormalities. Rapid delivery of intracoronary nitroglycerin reverses the spasm without occurrence of adverse effects. Focal spasm has been successfully treated by stenting. Both types respond greatly to calcium channel blockers and nitrates, with breakthrough attacks being aborted with sublingual nitro. In contrast to conventional atherosclerosis, beta blockers can worsen coronary artery. Coronary artery spasm remains a highly under-recognized entity. Right diagnosis leads to right treatment that can result not only in reduced mortality but also greatly improved quality of life for our patients. A careful follow-up of patients with insignificant stenosis and suspected coronary artery spasm at the time of initial diagnosis should ideally lead to a proactive approach to provocative testing. Thank you.